Very good afternoon, everybody. At the offset, I would like to thank AIS for giving me this opportunity today. I'm Dr. Sunandini, and I'm going to talk about viral keratitis, solving the enigma, and it will be case-based discussion. So we know that HSV is one of the most common causes of corneal blindness in the worldwide, and in India also, whether it is a rural or urban population, in today's time we see a lot of patients of the same. So before we treat the patient, we need to classify the patients according to the classification, which is infectious epithelial keratitis, neurotrophic keratitis, stromal keratitis, and endothelitis. In India, the most common forms of involvement are actually the immune stromal keratitis. In my practice also, I see them the most, and followed by the epithelial keratitis. Although I see endothelitis more than epithelial keratitis in my practice. So I will be just going through the various keratopathy cases first. So this was a stage 1 case. This patient was lost to follow-up, so I do not have any other pictures for this. So if you see, then this patient, there's a dry, cloudy corneal epithelium with punctate lesions on them. And in these kind of patients, you have to stop all the antiviral drugs and unnecessary drugs. And you have to put the patients on preservative-free artificial tear. This is another patient of mine where you can see this oval or circular kind of defect, and there is a rolled margin, and the sloughing has still not started. So in this patient's conjunctival flaps or partial tarsorrhaphies really work well. This is a stage 3 where the sloughing has actually started, and then or the corneal perforation has occurred. So in this patient, either therapeutic contact lenses or amniotic membrane transplantations, or in corneal perforations we already had discussed, so I will be skipping this part. So this was a case which was a 58-year-old female patient with a visual acuity of 4/60. The digital tension was normal, and she complained of redness and diminished of vision. The patient was already on to moxifloxacin, lubricating eye drop, pantogel, and homide. So what I just did was I stopped the moxifloxacin for this patient and the pantogel also, because it was already 2 months. And I just started the patient on preservative-free artificial tears and topical reconstituted insulin, 16 national per unit. So this is a patient's picture after 20 days of the treatment, where we can see that the defect has completely healed, and the surface will get better with due time. So there have been studies which shows that topical insulin works very well in refractive, and neurotrophic corneal ulcer. Traditionally, we can go from 1 international unit to up to 50 international units also without any side effects. Autologous serum is another treatment of therapy for neurotrophic keratopathy, but there have been various studies which also show that there are high risk of infections with autologous serum if not prepared well. So this is a second case which was an 81-year-old female patient who was very poorly built, maybe 30 kgs or so. She was complaining of pain, redness, watering, blurred vision from the right eye, and she had a history of trauma while getting an application tonometer done at some other eye center. So the vision at presentation was 6/36 part, and she had an epithelial defect with a lot of DM folds, as you can see. So thinking that she might have a infective pathology, and she might get lost to follow-up, I did not start the steroid in this patient, and only started the oral acyclovir half the dose, that is 200 milligram, and CMC eye drops, somatropin, Vigamox, and dipanthenol. But on the 7th day, the patient came out with a lot of anterior uveitis. So all the immunological and metabolic work was done, and they came out to be negative. The B scan was not having any vitritis. So then I started the patient on prednisolone acetate, and you can see that the patient started getting better. And this is the 45 days of the picture where the epithelium has healed, the DM folds have reduced, and the KPs are also gone. This is another very simple case, but this patient was getting treated by another colleague of mine when they came for a second opinion. So the patient was already on to topical antiviral drugs and lubricating eye drops, and you can see that there was a diffuse corneal edema with KP. So I started the patient on stop the topical antivirals and shifted the patient on oral acyclovir. Somehow I felt that this patient might be having a recurrence, and I started the patient on steroids and homatropin. So once the edema starts to get better, I can see that there were a lot of previous recurrent scars which were there. And when the patient really got much better and the edema has subsided, the KPs has also subsided, you can see that there were multiple scars in this patient, which shows that the patient was actually a case of recurrent viral keratitis. So stromal keratitis study has already shown that topical corticosteroids along with topical antivirals works very well for stromal inflammation and shortening the duration of herpes also. And oral therapies works very well for anterior uveitis patient. And then there was a study by which was for the stromal necrotizing keratitis kind of patient, where they did a 10 weeks regime of oral acyclovir and topical acyclovir, and at the end of the 2 weeks they started the patient on diluted prednisolone sodium phosphate. But they saw that when the patient was started at the initial of the therapy, the systemic and topical therapies were started, as acyclovir was started. So there was healing of the ulceration when the topical steroid was started. So there was the necrosis or the inflammation reduced, and initial therapies had a better outcome. So similar line of treatment was done for this patient. So this was a 53-year-old male where the patient was using some eye drops. The details were not known, and this was a completely sloughed out corneal ulcer. And we thought that this is non-infective, and the patient was not ready to get any investigation done at the start. So we just did a tectonic keratoplasty with the optical grid tissue. But at the 10th day, the patient developed this kind of epithelial defect with loosening of suture and graft edema. And we did the metabolic workup for this patient, which came out to be negative, and the RT-PCR was positive for this patient. So we started the patient on only oral antivirals, acyclovir, and the other steroid doses remained same. So this is the 30th day of the picture, where you can see that the graft has settled. There's remaining scar, and the suture line and the graft host junction has also got better. This is the last case that I want to show, which was a 50-year-old male who was operated elsewhere and was diagnosed with viral keratitis. The patient was operated 2 times for failed graft, and the patient was already on prednisolone, Vigamox, preservative lubricant, timolol, and Visolon. So patient, when he shifted to Delhi, he stopped the oral antiviral drug. So simply, if you can see that the patient had a lot of bullae, a lot of corneal edema, there were KPs, and the digital tension was also raised. So I just started the patient on valcyclovir again and did not change any treatment. And you can see that the edema starts getting better in this patient. So there have been studies which shows that adding oral acyclovir in recurrent cases reduces the chances of having an ocular SHV by 45%. So to conclude, prompt diagnosis and treatment can decrease ocular morbidity. Patient counseling is very important in oral therapies. Uveitis and glaucoma management should go hand in hand, and you have to believe in your clinical diagnosis and history, because that is the main line of diagnosis for these patients. Thank you.
Thank you, Dr.